Good evening, everyone. Welcome all the delegates on behalf of ARIS to this Crevast Academy. ARIS strongly believe in power of empathy and truth of science, and we practice that, and thereby improving healthcare outcomes. If you look at this slide, there are many patient care initiatives which we have started to improve the healthcare outcomes. Naming few of them like CGM on call, Holter monitoring, Cardinal, India Heart Study, ABPM on call, etc., etc. This really proves that we believe in power of empathy and truth of science. We started this Crevast Academy for having many events around the year. Basically, the objective is to disseminate the curated content amongst all the clinicians all over India to master the nuances in clinical management for improving CV outcomes. This Crevast Academy's objective is to guide clinicians across India to improve CV health in patients. Every second Saturday, we have this Crevast Academy event. And the first webinar we had on 8th April 2023. And the session was statins essential for diabetic health. And many eminent faculty members were there to participate along with the delegates in this first event of Crevast Academy. And today we have session 2, very interesting topic, statin optimization, and that's the need of the hour. And we have a moderator with us, Dr. Sanjeev Shah, who is a well-known endocrinologist attached to Nanavati Max Super Specialty Hospital, Mumbai, who has 40 years of private practice to his credit. And for 5 years, he was attached to KM Hospital. And he has been a researcher for the last more than 20 years in many global trials. And he has around 50 original research papers and 20 book chapters to his credit. That's the kind of personality we have with us. And I will request Dr. Sanjeev Shah to set the context and moderate today's session of Crevast Academy. Thank you very much and wish you a great academic session. Over to you, Dr. Sanjeev Shah.
Can I share the screen? Thank you, Mr. Gagan. Dear friends, today we have 3 important senior experienced cardiologists, and we have these 3 important subjects to discuss in a crisp manner. And we have, for many subjects, selected a small part of a topic or a single research paper. To begin with, we are going to have a discussion or presentation by Dr. Srinivas Rao on the relationship between LDL cholesterol and cardiovascular risk. As we have learned for years that it's a multifactorial disease and there are many risk factors, comorbid condition, and we learned from the days of Framingham study that what eventually leads to an atheromatous vascular disease. LDL or a total cholesterol is part of the risk factor profile and how much it is responsible. So before I invite Dr. Srinivas Rao, I would just present in about 10 slides that at what stage when you diagnose hypertension or diabetes, an individual is at a risk of developing a coronary or atheromatous vascular disease, either before the diagnosis or after 5 years or after 10 years. That automatically takes you to a question, who is at risk and how much risk? There are trajectories based on the number of risk behaviors and the risk factors associated with an individual. So individual is labeled as a low risk or a moderate risk and a high risk, and he would progress in the direction of a clinical event. Many times till an event happens, individual is not diagnosed for many years that he has an atherosclerotic vascular disease. When we look at an individual, we see at the periphery on the smoking, physical activity, unhealthy eating on one side, obesity or diabetes, or on the other side with insulin resistance, which is not being estimated, hypertension, and there are certain things which are not visible to us, like subclinical inflammation and other risk factors associated with an individual. Leave aside the ethnicity. For Indians, again, ethnicity is extremely important. So this was a simple age-old slide looking at all kind of a risk factor. And in all this risk factor, which are modifiable, and a lifestyle factor also being modifiable, how much LDL contributes to a vascular disease. We do not practice what we have learned about Framingham risk scoring. We also received many other scoring mechanisms. We would not go into the details of risk scoring, but you are supposed to estimate as a good physician that individual is at what kind of a risk, less than 7.5, 7.5 to 20%, or more than 20%. Without that, with risk factor also, we still remain uncertain for a given patient whether he would develop or not. We also learned in the recent years, based on all MISA study and publications on the subject, and we developed a new tool of diagnosing atherosclerotic disease like a calcium scoring. It's beyond the scope to go into the risk prediction and ability of MISA-based findings here. A new paper in New England Journal a couple of years back added a pollution in a heart. So an air pollution as an additional risk factor which applied to our metro cities all over the country. Finally, still the most important remains culprit in atherosclerosis is LDL. As put up very elegantly by Kaushik Ray in relation to a paper on lifetime exposure concept, it's a degree of elevation and duration of exposure. On the back of all the risk factors, we still have not reached where we estimate all risk markers in every single patient. But we do look at LDL in most of our patients. So that takes us to a topic of discussing relationship between LDL and cardiovascular risk. To present this particular topic, we have Dr. M. Srinivas Rao, who is a senior cardiologist, head department of cardiology at Apollo Hospital, Hyderabad. He had been in practice with a vast experience of more than 30 years, trained 60 fellows, had been an investigator in large majority of the trial from hypertension to India heart to heart failure, and has more than 30 publications. So as an expert in the field, Dr. Srinivas Rao is going to present to us LDL and atherosclerosis relationship. Over to you, Dr. Srinivas Rao.
A very good evening to all of you and to the distinguished gathering today for this seminar. And thank you, Dr. Sanjay ji, for your kind words. Thanks, Aris, for actually inviting me to this particular symposia. And as Dr. Shah was speaking, that today we are paying a great, modern plague, what we say, the atherosclerotic heart disease and vascular disease in India. And compared to any part of the world, we have the highest risk of developing atherosclerotic heart disease. It may be, it could be cerebrovascular, cardiovascular, peripheral vascular disease. So now we call as polyvascular disease. So some reasons when Indians we pay higher kind of penalty for the same kind of risk elevation compared to any other race in the world. So for us, it becomes very, very important and also imperative that we actually treat our patients to a larger molecular lowering of the goal than any other population in the world. So I will share my slides. Today I'm going to speak about my job today is to talk to you on I hope my slides are being seen. Are you able to see my slides, please?
Can make it in a full screen mode.
Yeah, yeah. Okay.
Yes.
Yes. Now, what I'm going to today speak about pathogenesis of atherosclerosis and how LDL cholesterol is related to atherosclerotic vascular disease. We know that we have vessels which carry blood to every part of our system, and they supply nutrition and oxygen to our every tissue. Now, this is what we have. You see, is a picture what you see intima and also endothelial cells. The endothelial cells are not just what we call a carpet. In fact, they are very big, active factory, I can say. They are very, very active in the sense the dysfunction of endothelium leads to a lot of vertical problems. So when we have this endothelium, which is like a carpet, usually it prevents any kind of seepage of these inflammatory cells into the intima. And then if suppose there's any kind of intimal damage, either by, as Dr. Shah was speaking to us now, that air pollution or maybe some inflammation because of some systemic disease, which makes endothelial dysfunction, endothelium becomes more permeable to this monocyte. And when the monocytes get in, we have these LDL particles already present there. The more the number of LDL particles, the more number of monocytes. What happens is there is a interaction between monocytes and LDL particles, and this monocytes engulf this LDL particle, and this ability of monocytes getting this LDL into them depends upon whether LDL is oxidized or not. So this is where the inflammation also counts. When you got what is reactive oxygen species, which are nothing but end products of inflammation, then you find LDL particles oxidized. Once they oxidize, they immediately engulfed by the monocytes, and then the monocytes, which otherwise are the macrophages in the tissues, they become a foam cell. Once they become a foam cell, then they're ready to actually have this again secretion of some more inflammatory markers, which again induce endothelial dysfunction, more permeability to endothelium, more amount of seepage of monocytes, which turn them into macrophages. And not only this, these inflammations also make LDLs oxidize. And once they get oxidized, they get engulfed with foam cells. And once the foam cells are formed, that is the beginning of a plaque formation. This, once the plaque is formed, more and more what we call this monocytes in the form of foam cells, which after engulfing the LDL cholesterol, they get into the subintimal area, and they form this kind of a plaque. Usually, the plaque is actually not very responsible for causing any events, but when the plaque actually gets inflamed because of secretion of some inflammatory markers, it becomes a vulnerable plaque, and this vulnerable plaque can rupture anytime and causing the subendothelial structures to be, exposed to the clotting of the blood, which actually has clotting factors, and thereby causes either subacute occlusion or complete occlusion of the artery, thereby producing acute events. Even if the plaques are not actually rupturing, they can grow over a period of time and can cause a decrease in the luminal size of the arteries, which are supplying the cerebral circulation, or peripheral circulation, or for that matter, myocardial, vessels, that is coronaries. And this is how the beginning of the plaque formation and causing of atherosclerosis develops. And this, the central role for the development is nothing but LDL cholesterol. The LDL cholesterol, of course, is modified by many factors, and then that leads to oxidation of the LDL cholesterol, which leads to what we call a engulfing by the macrophage, and thereby getting deposited into the submental area, causing a plaque. Now, this is how over a period of time the plaque forms when they have got LDL cholesterol. One of the root causes of ischemic heart disease, or root cause of atherosclerotic heart disease, is nothing but the dyslipidemia, or for that matter, the presence of LDL cholesterol in heightened levels. Not only heightened levels, but we also know that LDL cholesterol has to be oxidized, and it should be Also, those LDL particles which are actually small in size. The LDL particles are not uniform. In fact, LDL particles have got subfractions, and these subfractions you can see there is what is called as small dense LDL cholesterol particles. The small LDL cholesterol particles are more often seen in those people who got insulin resistance and in those people who got systemic inflammation. And even though we may have the net amount of LDL cholesterol to be near normal, but if we have more number of these small dense LDL particles, that it becomes more what we call pronounced atherosclerosis in a person. So not only we need to actually bother about the absolute level of LDL cholesterol, but at the same time we should also know how much there's inflammation that's circulating in the body, what is the inflammatory milieu in the body, and also what is the nature of these LDL particles, which are there? Are they high? What is called as small dense LDL particles are more in numbers or not? So this is also equally important for us. And then whether LDL cholesterol is related to the ischemic heart disease or vascular disease is one when we debate about yourself. We have plenty of what we call the data, both epidemiological, experimental, and also longitudinal studies by even at the social levels. We see there's a linear relationship between LDL cholesterol in a person and then the development of atherosclerotic heart disease or vascular disease. So when you find that every millimole, 1 millimole is 38.5 milligrams of LDL cholesterol when increased in the body, there is about 22% increase in the chance of having a CVD. And if somebody has an exposure of LDL cholesterol of this level, we have temporally, if you look at lifelong exposure, it almost becomes for 30 to 40% chance of having a CVD in a person. So the lower the LDL cholesterol, the lesser is what we call such kind of a formation of plaques, and then thereby development of ASCVD in the patient. And we have a experimental evidence to show that in animals, when you feed them more of this atherogenic diet, which increases the LDL cholesterol and thereby increases the ApoB, then it causes there is an increased amount of atherosclerosis in them. And when you deplete them with atherogenic diet and you reduce LDL cholesterol, there is also evidence to show that they have less pronounced atherosclerosis in them. So this is about experimental in the animals. Then if you look at genetically, the monogenic and polygenic mediated lifelong elevations of LDL cholesterol lead to markedly higher lifetime risk. The best evidence to it is the the presence of loss of function of LDL receptors. When you have LDL receptors and a loss in a patient, then in those patients you find that the atherosclerosis is highly mediated. When there's a gain of function of LDL receptors in the liver is there genetically in some of the races you see, there's very, very little level of their getting into atherosclerotic vascular disease. So this is a gain of function of LDL receptors and or loss of function of LDL receptors. Meaning to say that when you find the LDL cholesterol by virtue of having some genetic propensity to have ultra low level of LDL cholesterol, in those races you find there's less amount of atherosclerosis and no atherosclerosis, or in them where we have a heightened level of LDL cholesterol, like we see in the familial hypercholesterolemia, you find there's a lifelong exposure of high levels of LDL cholesterol, and you find very high level of atherosclerotic vascular disease in them. So this is of course what we see the monogenic and polygenic mediated lifelong elevations of LDL cholesterol, which we actually lead to heightened amount of atherosclerosis in the person. Then there are also trials which uniformly demonstrate a dose-dependent linear association between the absolute magnitude of exposure to LDL cholesterol and ASCVD as well. So the lesser amount of what magnitude of elevation of LDL cholesterol, less is what we call atherosclerosis that we see. The larger amount of atherosclerotic, larger amount of LDL cholesterol exposure that we see in the patient, you'll also see that these patients have a heightened amount of ASCVD in them. So there is a what we call a level and a not only level, absolute level of LDL cholesterol in a person, but at the same time, the duration with which they're exposed, the temporal relations between exposure of high level of LDL cholesterol to developmental sclerosis also is very evident. And then the monogenic lipid disorders, Mendelian randomized studies also demonstrate elevated LDL cholesterol precedes the onset of ASCVD. So many of these times when this, you can see in those families where this heightened level of LDL cholesterol, you may find them elevated LDL cholesterol may not have at the time of their detection of high LDL cholesterol, but you will see subsequently that ASCVD developing in the lifetime. So this shows that there is an exposure of LDL for quite some time before ASCVD develops in them. And the specificity is that Mendel randomization studies on randomized intervention trials also provide a unfounded randomized evidence of it that LDL is associated with ASC independent of other risk factors. For example, the person may have other risk factors like obesity or maybe having other risk factors like hypertension or diabetes. They have a very low level of LDL cholesterol. Their chance of developing ASCVD also comes down. So it is specific for, LDL cholesterol is very specific for development of atherosclerosis. Although we may have other factors may enhance the potency of the LDL elevation to higher degree of ASCVD development, but nevertheless, LDL is a baseline at which this risk of developing of ASCVD develops in a particular person. There are at least about 200 studies which are right from right from Texas and also from west of Scotland study, etc., where we have found that the patients who have got elevated cholesterol development, they are treated with elevated cholesterol, or in those people who got average elevation of cholesterol, where they are treated for LDL cholesterol reduction, or in those patients they have got near normal LDL cholesterol elevation, but you stated them for reduction in LDL cholesterol. At every level of this LDL cholesterol reduction, whether it may be heightened LDL cholesterol levels, average level of LDL cholesterol levels, near normal level of LDL cholesterol. At each time, when you reduce LDL cholesterol to a low levels, we found that in these studies that there is the lowering of the risk of development ASCVD. So this again shows the consistency of elevation of LDL cholesterol leading to ASCVD. Or when you reduce LDL cholesterol, there is a consistent reduced level of development of ASCVD. So now look at this graph again shows at each level of LDL cholesterol, whether 2 millimoles or whether it is more than 5 millimoles, there's a linear relationship with heightened level of ASCVD. For example, a person with the age of, let's say, about middle age, 50 to 59 years to 70 to 79 years, you find that the patient is been exposed to a higher level. For example, a person who is less than 2 millimoles of LDL cholesterol may not matter much when he is between 20 to 49 years or 50 to 59 years. But as we got exposure to a long period of time, temporarily we are exposed more longer time. When we reach about 70, 79, the same very low levels may mean that we have a heightened level of ASCVD development. So this again shows there is not only a linear relationship with the level of LDL cholesterol at any level of a lifetime, but at the same time, duration of exposure of LDL cholesterol in a lifetime, the longer the duration of exposure, the more is the chances of developing ASCVD. Similarly, events like myocardial infarction are also related to the level of LDL cholesterol we are exposed and duration of a level of cholesterol that we are exposed. Again, it shows for every millimole increase of LDL cholesterol levels with us, we also have a heightened level of development of myocardial infarctions. So myocardial infarctions are also known to be related to this level of LDL cholesterol. It's not only ASCVD, but the clinical events that we develop with increased chances of ASCVD also means we have clinical events going up like ischemic heart disease or strokes. Again, this it shows not necessarily the myocardial infarctions, but also other ASCVD events like stroke, etc., peripheral vascular disease are also really related to increase in the LDL cholesterol and the duration of exposure as well. So the relationship and with LDL cholesterol development ASCVD, and we again feel that this is the baseline with which we need to actually target prevention of ASCVD in a person with LDL cholesterol reduction. And we know that today with ample of evidence, which my colleagues are going to speak to all of you, that as we lower the LDL cholesterol, there is a incremental benefit of reduction in the ASCVD development in our patients or in our people or in our society. So cumulative exposure partly to high level of LDL cholesterol over a time is critical. And the lower the level of LDL cholesterol at any level, or the lower level of LDL cholesterol exposure temporarily to longer period is much more important in prevention of ASCVD. Thank you very much for patient hearing.
Thank you, Dr. Srinivas. I would request Dr. Muralidharan and Dr. Shetty to unmute yourself. Dr. Srinivas, there is only one question and the point of discussion between all three cardiologists, expressing your view in relation to a recent paper published by Paul Ridker, Deepak Bhatt, and Steve Nissen.
Yeah.
The paper was in Lancet 2023, very recent, with a title, Inflammation and Cholesterol as Predictors of CV Events in Patients Receiving Statin Therapy. This is based on the pooled analysis of a trial called Prominent, Reduce IT, and Strength. So in this paper, Paul Ridker is again bringing a point of an inflammation for CV events. As you go ahead, he shows in a graph that HSCRP more than 2 milligram resulted into more 3-point MACE as well as CV mortality, irrespective of LDL cholesterol more than 70 or a less than 70. So I would request Dr. Srinivas to stop sharing the screen, your screen, and you start first,
followed.
Point
you have brought it out. Yeah. Yes, I agree with you, Raksha, that you brought up a very good point. This is a very important point that we need to discuss. Many times we just look at the LDL cholesterol without actually getting other information from the patient. For example, patients who got high inflammation, that actually is also important. As I said, that LDL cholesterol forms the baseline, and there are other factors which make this LDL cholesterol heavily getting deposited into the submental levels and causing plaque. And then, of course, not only that, we also have evidence that even if you have a plaque, if somebody doesn't have inflammation, the plaque is very innocent. In fact, it doesn't cause any clinical events like myocardial infarction. But if you have inflammation, the innocent plaque, what it was there, which is not enough to cause any decrease in the blood supply in the myocardium or in the brain, it does actually rupture if the inflammation is there and then cause clinical events. So one thing is development of atherosclerosis. One thing is LDL cholesterol, the baseline, and the acceleration of this atherosclerosis is done by inflammation. Number two, the clinical events what we see in a patient with atherosclerotic vascular disease, the clinical events are also exaggerated by the presence of inflammation in the body. Exactly what happens in the case of or pollution. Patients who are having systemic disease like SLE or rheumatoid arthritis, patients who are obese, who have got abdominal obesity, who otherwise have a near normal LDL cholesterol, but they do have increased evidence of atherosclerosis. Why? Because they have more inflammation that is being synthesized by this dangerous fat what we have in intraabdominally. Similarly, patients who have got rheumatoid arthritis, SLE, etc., they also have height inflammation, and this is very evident by even some of the landmark studies like Jupiter trial, which has showed that people who had lower than normal expected to be LDL cholesterol, even they had a reduction in the events when they are given rosuvastatin, simply because the CRP fell when they given the statins, and this probably related to that particular event. And we also have canakinumab. We have seen that the patients who are heightened CRP, if we give this monoclonal antibody canakinumab for the CRP molecule, they actually improve in terms of particular reduction in the clinical events.
Thank you, Dr. Rao. We have a question and comment from Dr. Shetty and Dr. Muralidharan in that order. Dr. Shetty, this is labeled as like residual cholesterol risk. This is called residual inflammatory risk. Our listeners are consultant physicians, all MD internal medicine across the country in the range from 1,500 to 2,000 doctors currently listening. So would you suggest, when you see the report of HSCRP, how do you react? How do you stratify the risk? Do you take any kind of an interaction? How do you interpret and go ahead? Similar question for Dr. Muralidharan's comments after Dr. Shetty finishes on the same subject.
Thank you, Sanjeev. You can hear me, no?
Yes.
And I agree with whatever Srinivas mentioned. And this concept of inflammation, the first time, demonstrated by Ritker in Jupiter trial, and they showed, when the SSCRP less than 2, LDL less than 70, they have better outcome. But these are again a primary prevention trial. Now coming to the residual risk, what you mentioned, besides the inflammation, level of the LDL, level of triglyceride, LPA, and the thrombotic risk. Like now we are even looking into dual pathway inhibitor, like, COMPASS trial, where, small vascular dose of rivaroxaban also is considered. But anyway, that's a topic away. So when it comes to HRCRP, and, since you referred to Dr. Paul Ritker, in fact, in the AHA 2023, he gave a very nice presentation of inflammation, coexistent with dyslipidemia. And we know that atherosclerosis is a process of both inflammation and dyslipidemia. In fact, the canakinumab study, what he has shown, again, cannot be used in routine practice because of the cost. And now he strongly recommends use of colchicine. In fact, Coldoco and few low dose of colchicine in high risk inflammatory or high risk subsets, like a patient who have a recurrent event or a young patient, multiple comorbidity. In fact, we are using that in our practice, 0.5 milligram of colchicine in this setting, basically to reduce the inflammation. So basically what we do nowadays, we do the extended lipid profile. And when we have an extended lipid profile, including the LPA and the HRCRP, following statin or maybe statin as it may be and bempedoic acid combination, we look at the HRCRP at the end. And if the HRCRP has not come down significantly, if it is still high, one of the drug along with the statin, nowadays we are considering bempedoic acid. So basically HRCRP is a good marker of an inflammation, and we have to look into that in here. And if it is still high, maybe use of colchicine in a high-risk group substrate is required. And then aggressively getting down the LDL to take care of both LPA and of course the non-statin therapy for if the triglyceride is very high. And then I mentioned, the dual pathway, like a small dose of vascular dose of rivaroxaban. These are the 5 or 6 reasons why you get a residual risk instead of getting less sort of lower LDL, but still you have a residual risk. So we have to look into all these factors when you are considering therapy in these patients. And just few things comment about Srinivas's talk. 3 things we have to remember in one is, as he mentioned, is the cumulative effect of the LDL. Longer the duration, higher the LDL from the beginning of life, what is called as a cholesterol years, how we say smoking years and things like that. And the third, what we have to look into is the you are like a memory effect, like what we say in, for example, diabetic, you have got a metabolic memory. So also in lipid, now we have, OSCOP extension study, primary prevention beyond 20 years has shown that if you control LDL in the early part of life, and with a smaller dose of statin, even the requirement is lower, the effect can remain longer period in the life, something similar to diabetes and hypertension. So legacy effect, cumulative dose of LDL, and cholesterol years. These are the 2 or 3 things concept when you talk about LDL and ACVD.
Thank you, Dr. Shetty, for those excellent concept of thinking about how it would happen. Dr. Muralidharan, hyperuricemia is believed as a marker of oxidant stress and is linked with a risk of MI. And the colchicine now appearing here from Dr. Shetty. How do you see this so-called risk and strategy in addition to a statin?
See, though, as Dr. Shetty has nicely pointed out, sir, there are emerging evidence, but too early to enter into regular guideline armamentarium. We do use it in selected group or when we have no other child. But to come back to the same question of the last few minutes discussion, interesting thing, like we talk so much on LDL, yes, we talk on HSCRP, we talk on inflammatory. I was recently in a ACT meeting. The LDL seems to be conforming to all the Cox postulates, like causative agent. But we do have atherosclerotic heart disease even when the LDL is low, when the LDL is normal. So which is normal? How low we should go? That's a full debate of the today talk. But what I would like to stress is multifactorial. We have all the risk factors. We do have residual risk despite controlling LDL. So things like inflammatory markers, lipoprotein little a, or hemodynamic subsets, or other unknown things, or even hyperglycemia, diabetes related thing. And this hyperglycemia seems to be play a role. I will be a little afraid to say that it is the main thing, or we should try this in every patient. To be frank, today, I would like to have more data or more proof before adding it as a preventive strategy, both a primary or secondary.
Thank you, Dr. Muralidharan. So we occasionally, for a single patient sitting in front of us, we may take a decision, but we won't go into the policy part.
Yeah.
We move on to the next talk by Dr. Sadanand Shetty. He's a professor and head at Department of Cardiology at Dr. D.Y. Patil University, as well as at KJ Somaiya Medical College. Been founder of CVD India, president of Cardiology Society at Mumbai, fellow and editor of Clinical Cases in Cardiology, again a senior cardiologist with academic interest. Dr. Shetty is going to highlight and tell us about the lessons learned from cholesterol treatment trial collaboration. So extensive data and pooled analysis of close to 30 trials. Dr. Shetty, you can share your screen.
Yeah. You can see?
I can see the session 2, statin optimization.
Okay, you can see that, isn't it?
Yeah.
Yeah. You can hear me? Fine.
Yes.
For the same topic, and I'm going to touch upon the topic 2, as Dr. Sanjeev mentioned, the lessons what we learned from cholesterol treatment trial collaboration. Now, basically, the background of this particular talk, as we know, the CTT or cholesterol treatment trial collaboration is initiated almost 30 years back, almost in 1990. And the background reason is to assess the safety and the efficacy of more intensive lowering of LDL with statin therapy. Like whether intensive versus the lenient lowering of LDL is enough or not. Or whether lowering of the LDL to very low concentration have any adverse consequences. Of course, the adverse consequences Dr. Muralidharan is going to address, and that's a background. So what are the method here? We have a meta-analysis of individual participant data from randomized control trial involving at least 1,000 participants and minimum 2 years in every trial. That's what is the basic requirement. And of course, the more versus the less intensive statin. And what is more and what is less, we will discuss during our panel discussion. Now, if you see the results of all these CTT, 5 trials, 39,612 individuals, follow-up median 5.1 years, ACS patient 8659, and the stable coronary artery disease, what we call today as CCS, chronic coronary syndrome, is nearly 30,953. The trial is statin versus control, that is a placebo. Just to see whether statin is beneficial or not, we have 21 trials, almost 1,29,526 individual, and follow up nearly 5 years, exactly is 4.8 years. And what are the findings in this particular trial is that when you put all 26 trials together, the risk reduction was 24%, which is quite a significant p-value. See here, p-value 0.001 per 1 millimole, and that's what we were discussing every time. 30 milligram reduction in LDL is amounting to almost 24% risk reduction and 27% reduction in the non-fatal MI. Again, p-value is 0.001. Coronary death almost 20%, again p-value. So all these particular the findings are suggestive that statin benefits versus the placebo. Now, when you look at the findings of first coronary revascularization, the risk reduction was almost 25% by reducing 1 millimole, which is about 38.67 milligram reduction in the LDL, with similar reduction in the bypass and angioplasty. So almost 1 in 4 patient requiring, these PCI and the bypass, the risk reduction is at 25%. Coming to the major vascular event, when you talk about all 26 trials together, the risk reduction was 22%. Again, p-value is significant for the same reduction of the LDL, that is 1 millimole at the end of 1 year. So consistently between 20 to 25% reduction in various vascular event. First, the reason for doing angioplasty, bypass, etc. Now, what are the findings of the first major vascular event? Again, risk reduction is about 25% per 1 millimole reduction in LDL with no previous history of vascular. That means almost like a primary prevention, and reduction of 17% among women and 16% in people older than 65. So we had earlier some doubt whether in women it is as effect like men, but it is very clear now that even among women, there is a reduction in the risk after statin, maybe a little less than the men, but still it is statistically significant. So also in older people. Many times we think whether older people should receive statin or not, but again, CTT has very clearly given us clue that even in elderly people, we have got the benefit. Now coming to the stroke, the risk reduction is almost 16%, in high significant reduction in the ischemic stroke. And the first non-fatal stroke reduction is 23% as a primary prevention. Again, p-value is very, very significant. Now coming to the mortality reduction, all-cause mortality about 10%. Again, p-value is significant. Vascular mortality 13% reduction. Mortality from unknown causes 14% reduction. Again, 10 to 13 to 14% is the range. Coming to the cancer, many times we have a fear that statin can produce cancer. Whether CTT trial as a collaboration has given any indication, there is no evidence of an excess of cancer at all sites combined or at any particular site. Very, very important that there is no increase in cancer after statin therapy. So now, as mentioned previously by Srinivas, lower is better. These are the evidences. We have a primary prevention trial as shown in this light black color, all these trials, and the secondary prevention trial, various trials that lower is better. At what level of LDL you should achieve? In fact, Lipid Association of India, where I'm one of the advisors, we have a very clear-cut guideline looking at the risk, what should be the level of LDL. Like we have categorized into low, moderate, high, very high risk, and extreme risk, where category A and B, and accordingly, our level of LDL reduction varies. So based on the risk, based on primary or secondary prevention, our target should be a little different, which we'll discuss during the part of discussion. So what exactly the CTT collaboration given us the information that the size of the proportion reduction in the major vascular event is directly proportional to the absolute LD reduction that is achieved. As we discussed earlier, as Srinivas mentioned, absolute LDL reduction also, is also gives us indication of, atherosclerotic cardiovascular disease, early stage or later stage. So also how LDL reduction, how much absolute LDL reduction takes place after the statin is important. That is clear cut by the CTT collaboration. So further benefit can occur when you go to intensive statin therapy, even if the LDL goes less than 2 millimole. So much so that just a few days back, an editorial from Dr. Brownwald, where in very, very extreme high risk patient, even less than 10 milligram. Of course, the safety is quite okay, but again, we'll hear from Muralidharan about the safety of reducing LDL to 30, 20, 10, etc. But there is linear relation between the LDL reduction and the event. So in a very, very high risk, extremely high risk, there is a provision to use very, very the potent or a combination of various lipid lowering drug like statin, non-statin, and getting the LDL down. Each 1 millimole, which is about 38 milligram %, reduces the first vascular event by 1/5, irrespective of the baseline cholesterol concentration. Of course, higher the concentration, the effect of the statin is better, but which implies that 2 to 3 millimole per liter reduction would reduce risk by 40 to 50%. So if 1 millimole can reduce up to 38% 2 millimole will have directly, as I mentioned here, it is directly proportional to the absolute LDL reduction. So 40 to 50%, 60% or 70%. Like today, with the combo of statin, bempedoic and ezetimibe, we are looking at reducing the LDL almost up to 70% in very high risk patients. And also lowering of the LDL further in high risk patient achieving target less than 70 would produce additional benefit without any increase in the cancer and non-vascular mortality. So reducing LDL to 70, 50, 30 is safe, which Muralidharan is going to address. Even in LAI, Lipid Association of India, we are given a very clear-cut consensus statement about what LDL, when we should go to 70, when we should go to 50, when we should go to 30. And these are the benefits which can be safely achieved, with a more potent statin like rosuvastatin, can be even, 20 milligram, which is almost like a moderate to high intense dose is possible. Thank you very much for the hearing. And let me go back to Sanjeev. Yeah.
Thank you, Dr. Shetty. I have a very, very simple but extremely important question for all three of you. That physicians in clinic in practice do not use risk calculator by and large all over the world. So physicians perceive the risk of an individual significantly lower than the actual risk. And they look at an LDL value which seems to be okay, just little here and there, 105, 110, and do not give an importance to LDL. Finally, they end up using a low intensity statin. So what do you think, what prevents people when you have such classical finding in CTT and the Lipid Association still advocates much lower target than what came up in the recent even ADA guideline 2023 revised for diabetic people to go further lower. But physicians are okay with the lowest dose of a statin. A huge number of people receive that. So
Sanjeev, the question is very, very valid actually, but this is a problem. What we are talking and what sharing the knowledge and percolation to the ground level physician or a senior family physician, advising statin therapy, etc. There's a lot of inertia in there. So basically, as you rightly mentioned, therefore we, like in a Lipid Association in India, being a very close involved in as a core committee and the advisor, we are in the process of, sort of expanding the sharing knowledge to all the people. And 105, 110 is not enough for even in a primary prevention. And we have a very clear cut, as I mentioned during my talk. If you're talking about a primary prevention, low and moderate risk, the rough cutoff of LDL is about 100, which we are going to modify, moderate also about 70. And personally, I feel, just few days back, we had a discussion with the Kaushik Ray, who is the president of European Atherosclerosis Society, and I was moderating another session with the bempedoic, and he also believed, which I also interacted with him, 70 milligram percent, as even for a primary prevention in an Indian dyslipidemia, because in an Indian dyslipidemia means there are multiple comorbidity already there, like that metabolic syndrome, pre-diabetic, maybe central obesity, all when you put all these things together, it's almost like one risk or two risks, and we have a risk enhancer. Even when a patient who is a pre-diabetic or a diabetic, almost 50% hypertension is there. So considering that, prevention of, if you talk about prevention of a atheroma formation or arresting the progress, starting early age and also maybe at the age of 18, 20, as a routine sort of doing the lipid profile in a general population. In a high risk, you may advise at very young age, and knowing your LDL or lipid, the profile, including LPA at least once, will be a good way of knowing what is your risk actually. I would advise the physician, because here, like it is, we are teaching the teachers but actually the teaching should go to people who don't know about it. That inertia of, the therapy should go away, Sanjeev. The only way it is possible by knowledge sharing, and our information should go to a larger number of people, like we have 1,500, 2,000 delegates have, listening to us. So also tier 2, tier 3, smaller town also should reach. And that is what we have taken a big, step in LAI to sort of, percolate into the entire country. In fact, today, LAI, most of the consensus statement is very well accepted by National Lipid Association, USA. All our consensus are put in the NLA paper. In fact, in European guideline also, consensus, European Atherosclerosis Society, the discussion is on Lipid Association of India consensus statement, because Indian dyslipidemia is different than the Western. Unfortunately, many our webinar meeting, we still touch upon Western guideline and we discuss that. For example, ESC now, by your score criteria, they give 55 milligram LDL is the highest level of LDL reduction. Whereas in our LAI, we are given an extreme risk provision of even reducing to 30. That is, category B. Reduction of less than 50 in category A. And now just recently, today only, we have introduced one more category called C, which is very extensive risk, diffuse coronary artery disease, multiple procedure, CKD, and diabetes, insulin dependent, time and again, you do angioplasty, within 6 months patient come back, you do surgery, the bypass surgery, they again have a symptom. These are the areas where we have to get into this. And today, with an advent of, like a simple non-statin drug in our country, at least bempedoic acid, ezetimibe, I personally feel we have to be very aggressive. So only way I would say that the knowledge percolation is the only way, and that physician inertia should go away.
Thank you, Dr. Shetty. There are going to be half a dozen clips of a shorter video clips would be developed out of this 1 hour session and would go to almost 15,000-20,000 physicians on WhatsApp, which are more easily visible and which would give a message. Dr. Muralidharan, your input before we get into a very next is another exciting question.
Okay. Like you said, the major inertia is only, as you said, we don't do risk factor, risk calculators usually in our practice. But that doesn't mean that our physicians are not aware. Rather, there is a sort of inertia both for the patient side and doctor side, how much I should reduce, how much I can give a drug. The high intensity therapy, and often I used to tell in many of the discussions, we talk high intensity therapy, we immediately think I have to give highest level of statins and forget it. It was rather wrongly construed even based on AHA guidelines. But in reality, you give high intensity therapy or high dose statin, what we mean is a LDL reduction more than 50%. We all know that. That is rarely stressed by the medical community or the pharma industry or even by the guideline. But as Dr. Shetty showed, we know the evidence. We know it is not the milligram of statin you are giving, rather the milligram of LDL that's going to come down, the actual absolute level of the LDL. So that should be, that idea should percolate down and down. We know lower is better, lowest. And I would like to quote, being a want of time, I like to quote one quote from my close friend, Dr. Rajiv Agarwal, was with me 2 days back. He said, among the risk factors like hypertension, diabetes, and hyperlipidemia, excessive treatment can cause hypotension, symptomatic problems. Excessive diabetes treatment can cause hypoglycemia, but there is no clinical condition called hypo-LDLemia or hypolipidemia. You can reduce it to the lowest level possible, and enough evidence have emerged, which we are going to talk from Fourier trial, Fourier OLE trial, everything has said you can keep on go down on the LDL level safely, which is going to be my talk next also. So that is the main thing I like to impress. We have to understand, not just give therapy, but monitor the LDL, take it to the lowest point, early, sustain, long term, and very early in the life of the thing, because we know the risk of cumulative LDL also over lifetime.
Thank you, Dr. Muralidharan. Sadanand, 2 situations. On the left, we are very familiar with a word called treat to target. We evolved with kind of a, and if there is a baseline of 140 and I give one first dose of a statin, I reduce 30%, come to 100. So a concept of treat to target versus a percentage reduction, where your goal is 50% reduction as minimum, irrespective of baseline. So what is more protective as a message to all listeners? Percentage versus just a target of 100 or 70?
No, the simple thing, Sanju, again, as I mentioned, one side is the risk, one side is the target area. Whatever you are saying, 50% reduction from the baseline, at least you must achieve 50% reduction. That's what, many researchers say. Many times, now we have got many drugs like bempedoic and we are using azitumab routinely. But, even with the high intensity statin, at the most 50-55% LDL reduction is to be there. Therefore, the percentage, because we didn't have any other drug. Today, because we have drug, we are going beyond 60-70%. For example, if risk is low or a moderate, and you know that 10 milligram of, say, rosuvastatin, will reduce at least 30-35% from the baseline. And if your LDL to start with 110 or 105, I think it is reasonable. Then again, it depends also on whether it is a primary prevention or a secondary prevention again. Because, secondary prevention, your target will be a little different. Actually. So when you are talking about treat to target, depending upon the type of cases, particularly in case of secondary prevention, I would say, probably in a high risk, etc. Whereas getting the LDL down 30% by 10 milligram, or maybe rule of 36% by 20 milligram, or I may use a combo of azitumab 10 and rosuvastatin 10, getting almost like a 40 milligram rosuvastatin. So it's a simple arithmetic. I don't think, routine run-of-the-mill case, primary prevention is in your clinic that your LDL is 110 or so. There is no way you should get down to 50-55. What, Muralidharan said, like Rajiv Agarwal is also our colleagues and all, is like, yesterday we were discussing 10 milligram, and he says post PCI, I will keep all patients on, the LDL to less than 10. So point is, when you are advised to the mass in the community level, and an individual level is different thing like that. So I would consider treat to target is more in probably, little higher level of LDL to start with, and maybe a secondary prevention, I would say. And I would calculate by simple mathematical calculation, how much is the LDL reduction occurs a 10 milligram rosuvastatin or a 20 milligram rosuvastatin or rosuvastatin with azitumab or rosuvastatin with bempedoic with azitumab like that. So I'm not for, straight away treat to target in there. Whether the dose is important or the target is important. Like, the talk which we sometimes make and we debate, it is little at the end, we have to individualize. I would not go by saying, straight away go to the, but I would say that calculate the risk. Calculating risk means, I don't think, we require too many things. When a patient comes overweight, hypertension, smoker, diabetes, he has a dyslipidemia, he already comes in the, like a moderate to high risk group. We did not, like a Q risk score 2, or we can also roughly say what is the lifetime risk by looking at his multiple risk factor, and you can easily apply that. I don't think we should calculate the FRS immediately at that stage. And when patient comes for follow-up also, that figure is very important. When he comes to our office, next time, what is his weight, what is his BP, what is his A1C, and what is the lipidemia, dyslipidemia, or the lipid level. We have to emphasize on the patient, this is what we want.
Thank you, Dr. Shetty. So this automatically, the bench is proving, and academics have proved that we need to use little more high intensity statin more frequently, moderate intensity more frequently than low intensity. That automatically raises a question in the mind of a physician who have not looked at how safe is lowering of an LDL cholesterol. So let's invite Dr. Muralidharan, who is Director of Cardiac Cath Lab and Cardiology at Ramchandra Medical College in Chennai. Again, a senior cardiologist, more than 30 years experience, president of CSI Chennai chapter, academician, part of many trials, principal investigator, and more than 300 lectures. Over to you, Dr. Muralidharan. You would be sharing, or?
Yeah, you will be sharing. Thank you, Dr. Sanjeev ji. Could you please open the PowerPoint? Can you run for me? Yeah. Yeah, from the 71st slide.
Oh,
no 71 slide. Yeah. Okay. So already we have set the tone of the floor. We all know the need of the day, like how low we can bring in LDL cholesterol, and how do we bring, and is it good by the method we use. So we have now in today's pharmacological armamentarium, we have LDL-C lowering drug. The mainstay even today is statin, but newer drugs have come. Ezetimibe is in. We have bempedoic acid, things like PCSK9 inhibitor, and but we have interfering RNA inclisiran in the pipeline to enter into Indian market particularly, and we have other drugs like Evinacumab. So we have several drugs. They are well studied in pipeline, in phase 2, in phase 3 trials. What do they say? What is the level of it? See, if you see in 1980s, the target, as we discussed in the last several minutes, the target of 155 milligram LDL-C was accepted in 1980. Today, in the latest combination therapy, we see what is the LDL cholesterol we achieve, how effective it is. We'll go to the next slide. Various trials we have discussed already when Dr. Srinivas talked, when Dr. Sadanand discussed, several trials from 90s to 2020. The LDL targets keep on coming down. We have come to 1 millimole, as rightly said, 38.8 milligram, or to make it simple, around 40 milligram of LDL is now being aimed by several international bodies. More with in Indian context, Lipid India recommends even up to 30 milligram per deciliter of LDL. That is what we expect. That is what we would like to achieve. So in terms of clinical benefit, the lower is better. Is there a stepwise decrement in ASCVD risk? What do the evidence say? Next slide. We know very low levels, like people with the genetic variants, with PCSK9 loss of function, the LDL cholesterol is 0.39. 0.39 is something like in the single digit or just 2 to 8 digits of LDL cholesterol in milligram in Indian context. No major adverse outcomes. That's the first thing. So we know by genetical, Mendelian trials, and drugs also, lowering the LDL cholesterol is not at all harmful. Risk associated with pharmacology LDL cholesterol, if you look into it now, I know LDL bringing down is fine, okay, from a physician point of view. If I'm bringing it down, how am I bringing it down? The method I use, the drug I use. So risk, one is linked to profoundly reducing LDL cholesterol, which we know it is working. But the adverse reaction with the drug use, the known drugs that we discussed now, what is the response? Next slide. So we go to one of the recent trials, Fourier study, and I would like to invite our interested readers to go to the latest thing published just 2 weeks back, Fourier OLE also, that is open label extension studies for more than 5 to 6 years. In 10% of patients, the LDL cholesterol they reach for 19 milligram per deciliter. So you reached with a drug like a PCSK inhibitor, very low LDL, and there was no significant difference in treatment emergent adverse event compared with those who had higher LDL-C. Go back to the previous slide, please. So what we know is there are drugs which potentially reduce without a significant adverse event. Moving to this, the known adverse event, the fear. Next slide, please now. Because we don't use PCSK9 that frequently, but we do use statins very, very commonly. Few fears. One is I haven't even brought in here, like the risk of diabetes, very low, 1 in 1,000 patient here, and the benefit is much so overweighing when you compare with this. So we are not much worried about it. Statistically, looking at cataract, no evidence increases. Looking at stroke, hemorrhagic stroke, we know very clearly the risk is not increased. Any cognitive impairment, neurological changes, no evidence that statin adversely affect cognitive function. So, and looking at other symptoms like statin associated muscle symptoms, though they are there, they are not a dangerous one. So, in important additional factor that we see here is that means bringing down LDL is not bad. Bringing down with the known drugs like statin, PCSK inhibitor, ezetimibe, there seems to be not increase adverse events because the type we are looking at here. So at this point, how am I bringing on mechanism of action? The mechanism of action is different, like those increase the LDL clearance, all the drugs I mentioned. Go back to the previous slide. Previous slide, please. Whereas drugs like blocking lipoprotein production, they are in trial, yet to be used in countries like India. Next slide. Drugs like mipomersan and romitapide carries a risk of complicated fat accrual in the liver. So too early to say discredit them or taken. But the available drugs today, though cost effectiveness can vary, the common drug we use like statins, the common addition we use like ezetimibe or bempedoic acid, or the rare thing we use because of the cost limitation like PCSK inhibitor, all are seems to be very, very, very safe in the situation. Next slide. So to the lack of effect of literature, Sadan Shetty also showed the risk of cancer in 27 randomized trial, median treatment of 5 years, statin therapy had no effect on the incidence or mortality from any type of cancer. So it is not causing any major adverse effect from the oncology point of view. Next slide. As I said, statin in muscle symptoms, we will be discussing now. As I said, it does. We do see reassurance, making the patient understand the benefit. Most of the time we can save. Liver function abnormalities, though they are very rare, we have to monitor. If necessary, only very, very rarely, we may have to tone down the dose or withdraw. Next slide. So to conclude, my friends, LDL-C levels below the goals recommended by ESC or EAS, there is no discernible harm. From either very low level of LDL or the drugs used to bring down the LDL to lower level. So aggressive LDL-C lowering is safe and effective therapeutic strategy. Next slide. And next slide. Okay,
So
we'll
this
go for
is the
discussion.
last slide.
I'll stop here.
So as the screen is on, I'm not sure Dr. Srinivas Rao is there or not with us. He was in a cath lab, but we still have a couple of questions. Continuing the story of safety, before we go on to other subjects, Dr. Muralidharan, I have a couple of questions in relation to what we see that a brain is 20% cholesterol and a lot of neurological function where brain cholesterol is involved with synapse development, formation, axonal elongation, and whatnot in neurology in myelin sheath. So broadly, which we have put it as a in a neurodegenerative disease like Parkinson, Huntington chorea, and dementia, how much is the risk with lowering of cholesterol? We
Stop
still
sharing.
have potent drugs and a combination coming up.
Muralidharan, stop the screen sharing, I think.
Yeah, I am sharing, so I will stop.
Okay. Yeah.
So would you like to answer on, and then we take up Alzheimer as the next point, dementia and Alzheimer. But was there any kind of a concern with other 3 neurodegenerative?
Yes. Dr. Shetty, do you want me to answer?
Yeah. You are
Yes,
answering.
sir.
Or,
Yeah.
you are answering. Yeah.
So, sir, as we saw in my presentation also, the data doesn't support that there is any increased harm like cognitive impairment with long aggressive statin therapy and going to very low LDL level. There it puts it, as you rightly said, sir, from a basic physician, for me also I had the doubt for over years, like for development of neurons, myelination, as you said, for hormones. These are the common fear for an astute clinician you will be asking. But in reality, what is the LDL level in a newborn? We all know the neurological development doesn't complete at the time of birth. It does continues for several months after birth. At that time, what was the LDL? What is the LDL level? We all know a normal child today, wherever in the globe, the normal LDL level is around 20 to 25 milligram LDL cholesterol. So if 20 to 25 milligram of cholesterol, LDL cholesterol is sufficient to give a normal growth and development of brain, which is not yet completed, then I think that's a robust evidence we can reach up to that level, sir. That is how I look at this particular aspect. So we know now by data also, by Fourier trial, by ODC trial, single-digit LDL, still patient was not having any significant cognitive impairment. So 2 ways, biological proof, what the newborn child has LDL, and the data evidence, efficacy by Fourier and ODC trial. I feel a low LDL is safer to achieve.
Thank
Yeah,
you.
other thing, just to answer to that, Sanju, what Murali said is right. And many neurons and the brain, they produce cholesterol by their for requirement. they don't require from the system. You don't require, the cholesterol to go across the blood-brain barrier if you're talking about dementia and anything like that. Because brain produces adequate LDL for its survival. Like, placenta secretes adequate light. There are many organs and tissues which, secretes, its cholesterol for its requirement. It is a simple, it's just synthesized, and therefore, whether you get the LDL to 10 in the circulation, it is not going to affect that. Therefore, it's very clear now, because the safety, even the lowest after these all, OLE, our PCSK studies, and then there are some studies like Eugene's trial where, they have shown Pacman trial in acute MI trial, where, average LDL about 20, 25, between 20 to 30. Yeah. And then as Murli rightly mentioned, the newborn is roughly approximately 25. And therefore, when you talk, only point is, as Murli said, the less than 10 or 10 to 20, the requirement may be only in 10% at the most, in our routine day-to-day practice in extreme. To make it lower is better, go down to 20, 15, 10. As far as I'm concerned, I'm not for it right now. Because what Brownwald just in an editorial comment in our one of the renowned journal, he mentioned we need a trial now where millimole, like we say 1, get down to 0.6, 0.9 like that, and show that there is outcome. So that will be probably long process. So at this point of time, lower is better, but individualized.
So thank you, Dr. Sadanan. I also came across an interesting reading. As a curious listeners might have a question that there is a de novo synthesis of cholesterol in the brain. And the first question came to my mind that half-life of a cholesterol in blood circulation is limited to very few days. Yeah. But I found a surprising finding that half-life of a cholesterol in the brain is anywhere from 6 months to 5 years. That even if something produced de novo would last for a long period of time. The brain is significantly independent of blood cholesterol, which is not necessary for brain functioning.
And the requirement also may not be as much as what we look at the endothelium and all. It's a little different effect here. Differential effect.
Shetty, there was another paper I came across, was a meta-analysis and observational studies in European Journal of Preventive Cardiology, which looked at 36 studies and pooled analysis, which showed, in fact, statin reduced the incidence of dementia by 20% with a hazard ratio of 0.8. And for Alzheimer, from 21 studies, showed the risk reduction by 32%. So statin was more protective for dementia and Alzheimer rather than considering as a harm. So
this is a very important concept, and you are discussing for the delegates, and like even stroke. At one time, hemorrhagic stroke is that. In fact, we have no consensus statement of using statin in stroke, and we have to these all again tells us these all are vascular disease in here. This microinfarct, all these lacunar infarct, etc. Many times when you do the MRI study, there may be multiple small, infarct in the brain. So when you are protecting the vascular system, there is a outcome benefit. Whether you talk about the dementia due to vascular cause, whether you talk about, ischemic stroke and things like that. And we have, recently published consensus statement how to use statin in stroke, even in an acute stroke, And that fear among the physician that one trial, miracle trial, which was, in the past, where if you use statin, it will make ischemic stroke into hemorrhagic transformation, is no more valid today. So it's right point what you have come out with, all those, the cancer, dementia, Alzheimer, and the downside of getting the LDL. But my only concern at this point is to the larger crowd, that we should not be saying 10, 15, 20, safety is fine. But to get that, we have to also give more dose of the medication. Now, you said triple combo today can get the LDL to 70, 75%. But is it really required for us? Because we have to, one, cost is always an issue in the community, plus add-on drugs will have some of the other side effects. They are not like totally placebo. Like now we talk about diabetogenic effect of the statin. A person who is pre-diabetic or has a tendency of getting diabetes because of family history, obesity, obviously, high intensity statin incidence will be little higher. It's not a big deal. Today we can treat diabetes and we can reduce the statin into moderate dose. In fact, now after the racing trial, which is a recent trial, moderate intensity statin and ezetimibe may be a little superior to the high intensity statin because of the safety. Because one thing, important thing, in statin, all the things are related to the dose of the statin. Like intermediate to low dose is little safer in long term also, along with ezetimibe and maybe with the benzodiazepine.
Yeah, so probably the physicians
Yeah,
would use
yeah.
20 plus 10
Yeah.
rather than going to 40 with a
Yeah,
similar results and a lower statin
Yeah,
and
I
related
think-
issues.
yeah, I agree with you.
So with that, Dr. Muralidharan is still there, or Dr. Murli has left to conclude with as the time is moving on. For listener friends, I would rather like to tell you the final message as a concluding remarks, that your clinical performance improves when your patient's outcomes change. By your active clinical reasoning for each patient you treat, try to select what is best for him to prevent a future cardiovascular disease. And so that would change the outcome of your patients in your clinic. And that's a solution to clinical problems. All of us at large practice little better precision medicine, we would have a better outcome. With those words, I would hand over and close the session for final words to Aries team. Khushbu.
Yes. Thank you, all the speakers and delegates, for being part of today's Crevast Academy. I'm sure the insights shared by eminent cardiologists today, along with Dr. Sanjeev Shah, will certainly help improve clinical outcomes. We look forward to connect again under the same banner of Crevast Academy on 10th of June, that is second Saturday next month. Thanks again on behalf of entire Aries team. Wish you all good health, good night. Thank you.
Thank you.